I mean, when I was in nuclear medicine department, I have seen some patients treated with agonists of somatostatin radioconjugated, and you're right. In majority of cases, they use the imaging techniques.
Mhm.
I don't know because I don't have really access to the totality of the patient cases. But what I have seen is that they try to include patients based on their there is a huge evaluation based on the some kit of diagnostic using some radiolabeled radiolabeled somatostatin receptors, and based on the imaging they can judge if they could include or not patients with some with Glutatera. It's the molecule which is approved actually in some neuroendocrine tumors expressing the somatostatin receptors. But I think that in the guidelines before the treatment of with this Glutatera molecule, patients should be treated previously with the non-radiolabeled, just the agonist of somatostatin, and after some resistance or after some non-response, they can be treated with this molecule based on the imaging.
Yes, a lot of factors should be taken in attention for choosing the appropriate method for medication in case of such grave and serious diseases as pituitary adenoma. And it could be economics factor, it could be effectiveness factor of different variants of the treatment, it could be side effects factors. We should take in our intention, and of course the general patient condition and additional complaints, additional pathology which patient could have, all of this factor should be analyzed, and after that make conclusion about what is the best variant for the patient treatment. Of course, some statistic is present, what methods are more effective, what medications are more effective in case of pituitary adenoma, but in the same time we make analysis of all factors in which are present in the definite patient case, clinical case. But when you have some your own experience with this group of the patient with this pathology, you can make for us some short report about this information, because sometimes theoretical knowledge and practical knowledge, I cannot say that are different, but for us the information become clear after analysis of practical information and so- some personal experience. So when you have this information, you can deal with this information. You can share this information in our group, and I think it will be very interesting for everybody, maybe for you too, because you have ability to look at this problem and this pathology one time more and make analysis for theoretical knowledge and your practical experience. Okay.
Doctor, I have one point.
uh,
If we really do, we want to perform the biopsy, how practically we can do biopsy? Because pituitary gland is are surrounded by bone, I mean, sella turcica, and how we can do that?
yes, I think it's reasonable to provide biopsy only when we have ability to make transfemoidal access to this, because make craniotomy or treponotomy, I think it isn't reasonable. And the position or location of the pituitary and of course adenoma 2 isn't comfortable for is deep, and it's more one difficulties to performing biopsy, and one more reason why do we don't do in routine methodics, in routine diagnostic, biopsy of pituitary.
Uh, Other point, can we use CSF information? I mean, sampling from the cerebrospinal fluid uh, sample. Do we have, because it's surrounded by CSF, it's blanked the
I didn't meet
no.
this information in the literature. I cannot answer you to. You ask very serious and difficult questions for understanding the functional stage, functional level of pituitary adenoma. It's enough to determine level of hormones in the blood, in circulating blood, uh, in saliva too. And when we control these levels, sometimes we should control these levels in the different part of the day, during daytimes, during night times, according to circadian rhythm of producing some hormones, for example, growth factor, growth hormones. Uh, but this test, I don't know, is it reasonable too or not? I think
Because it is surrounded by CSF, the pituitary gland.
I understand, but pituitary gland eject hormones into the
Yeah, yeah.
bloodstreams first of all,
Okay.
and so we control level of hormones in the bloodstream. Uh, and of course, we can find markers of adenoma, uh, tumor markers in the blood circulating, uh, so we can control, or we can find tumors DNA in the blood too, but we should provide specific test, and I think not all clinics could provide this test too, because they are very specific, and I'm sure that they are very expensive too. Not each insurance can make this uh, can ability to provide this test, and maybe it isn't reasonable for scientific researchers. Yes, it could be, but for routine practice, uh, they aren't provided yet. Maybe later we will deal with these variants of the test too.
And the surgery would be through the mouth, I mean, through the nasal, or how is the surgery to remove the pituitary gland? The surgery.
The best way for surgery is transfemoral access. This is the best variant of surgery. But when it's impossible, uh, doctors could provide craniotomy or trepanotomy for removing of the pituitary adenoma. But the best variant is transfemoral access.
Okay, transfemoral. Okay, I looked in Google. Okay, transfemoral. Thank you.
Through the uh, you can read it's with endoscopic it's endoscopic techniques with minimal
Minimal
Invasive,
invasion.
invasive, minimal
Invasion.
invasive.
yes, yes, yes. So it's the best variant. It's the best variant for patient, uh, and the best variant for surgery. But not always it's possible. And of course, after surgery, we will do biopsy, and we will have results, and we can determine type of their tumor, and maybe we can determine some receptors for choosing later medications for controlling over the patient's condition, because not always patient could have good result after surgery too. Patient could have recidives of the tumor again, and type of the tumor can be changed, and patient could have malignant later malignant variant, and again we should use the medicine for decreasing level of the hormone. So we need this information for the future control over the patient condition. But in routine practice, I didn't have information in the literature about possibility biopsy for choosing the medicamentouse treatment for such a group of the patient. So, do you have more question about this variant of pathology, or can we do other discussion and other clinical case presentation?
Yes, we can. I think that we can do another case presentation if you have, please, doctor.
I just open the next. Next patient, a 21-year-old man, was admitted to an outpatient polyclinics with symptoms of polyuria and polydipsia. He was complaining about excessive thirst for all day long and continuous water drinking, with constant urination throughout the day, reaching up to 10 liters a day as stated. In anamnesis morbi, patient has history of falling while he was working in a building zone as a construction man. He had fallen from about 3 meters height and hit his head to ground a week ago. The falling was due to a stumbling, though it was not because of an epileptic episodes or syncope. The patient did not have any known medical history or any history of taking medication. So previously, he was healthy. He told that after the fall, he had a blackout during about 20 minutes and was taken to the city hospital's emergency service. In addition, he, he was, when the doctors examined the patient, his Glasgow coma score was documented as 15 in the emergency records after 30 minutes of the trauma. Glasgow coma score you can see in this picture. I make bigger it. So we assess three components. Uh, Visual disturbances, eye-opening response, uh, and for each changes we give some balls, some points. No response to pain, to speech, and spontaneously. Verbal response. No response means minimal balls, and maximal balls is when the patient is oriented to the time, personal details, place, and in surrounding. And motor response, no response again gives minimal balls, and maximal balls when the patient can perform any movements when he or she wants, and these movements are adequate. Uh, Patient have the maximal ball. So the maximal ball which patient could get in this score is 15, and it's mean adequate patient condition. Uh, when the patient has less pulse or when the patient has minimal pulse, it means coma condition or maybe different consciousness disturbances could patient have with less pulse than 10. So our patient had 15 emergency records after 13 minutes of the trauma. Then he was discharged after the first evaluation as no acute pathological condition was detected on laboratory studies, including serum electrolyte levels, urine analysis, CT scan of the brain. After that, he didn't experience any changes in his condition. However, he came to the hospital with symptoms of polyuria and polydipsia persisting for some 7 days after the injury. And the initial laboratory results were follows: serum glucose level in normal range, sodium in normal, potassium normal.
No, but sodium is we have hypernatremia here.
Yes, a little bit. Yes, increased level of the sodium. I'm sorry. Potassium is in the normal range. Calcium a little bit increased too. Albumin a little bit increased. Blood urea nitrogen is also increased. Creatinine is in the normal range, but in the upper level. Urine density uh, is sharply decreased. Serum osmolarity is 3027, and urine osmolarity is 234. Uh, do you know the normal ranges for serum osmolarity and urine osmolarity?
Serum osmolarity, it's 295, 295, I think, milliosmol kilo.
And so our patient has increased of serum osmolarity. And what about osmolarity of urine?
I think that it's increased because uh, I think that I think that I don't know. For me, the urine osmolarity and the serum osmolarity will be the same. No, the ratio between this. I think that we calculate the ratio and we try to find if we have a rapport of one or not when we have hyper osmolarity.
I want to find the definite parameters of it, but maybe a little bit later. So, uh, what problem can you suggest in our patient? What are the main symptoms? Uh,
Hyperaldosteronisme. There is
No, yeah, but
Kamran, yes,
yeah,
what is your opinion?
I think he or she has a diabetes insipidus
Why
because
do you think so?
polydyspia, high thirst, and then the urine specificity is also 1003 is all very near to the diabetes insipidus.
Too low, yes?
Yeah,
Specific
this
gravity
is
of
the marker of the diabetes insipidus. That is my point.
I
it
think
could,
just
but
doctor, sorry, for the normal values for the osmolarity in urine, it's between 600 and 800. For the plasma, it's okay. It's 295 and 310. Here we have little, I think, low osmolarity
mhm.
for the
So
plasma.
uh, a little bit increased
A
serum
little bit increased,
osmolarity
yes, okay,
and
osmolarity. And
sharp.
for the urine, it's low because the normal is between 600 and and 800 milliosmol.
Thank you, Manel, for this information, for this data. So we can say that urine osmolarity is sharply decreased and serum osmolarity is a little bit increased. Uh, what's One moment. Kamran suggested that patient could have specific type of the diabetes in solidus diabetes. And what do you think about this clinical case, and what differential diagnosis should be done, and what is a reason, possible reason for this pathology can be found in our patient? Does he has reason, some reason, or
It's a traumatic reason here. I think that there is some maybe destruction which will conduct to this diabetes insipid. I think that here the traumatism could be the cause of this diabetes.
yes, the most frequent reason for this variant of disease is brain injury, brain trauma. Our patient has not very grave trauma, but he was unconscious in unconsciousness condition during 20 minutes. It's a grave symptom. But after unconsciousness condition, he goes back to the normal state without any complaints, without any pathological changes. So we make conclusion about uh, light variant of the trauma. Uh, yes, Samrin, what do you
Uh,
want to
yes,
add?
yes, doctor. So I do agree with Kamran with the diabetes insipidus. I think because of the fall that happened to our patient, it kind of like affected his the fall can be like can be a reason why his hypothalamus or his pituitary it kind of like was disrupted. Uh, some sort of like normal secretion of ADH or something, and that can lead to the this electrolyte balance can be like disturbed too. Hence, there is this hypernatremia, which is like one of the exhibit symptoms of DI, as well as the hypercalcemia can be happening because of the increased urine production and stuff like that. Um, so I do agree with Kamran's um, this thing.
I understand your opinion. And why this patient has not so grave changes in the electrolytes level, in the serum osmolarity, in the same time, this patient has so sharp changes in urine osmolarity. Why this changes not equal? Uh,
Can you repeat your question? I didn't get you.
our patient has small changes in the blood level of electrolytes, for example, increased sodium level, increased serum osmolarity a little bit, but in the same time, patient has sharp changes of urine osmolarity. Why our patient demonstrate so light symptoms from the blood and their grave symptoms from the urine?
Maybe doctor, like, is this one of the reason? Like, maybe we are like, I don't know. Is it because of the compensatory mechanism?
Compensatory mechanism and one I think the one reason for not significant, not so grave changes in the blood due to duration of the problem.
Maybe it's too early, doctor.
Patient has trauma 7 days ago, only 1 week ago, and for more significant and more grave changes in the blood, it isn't enough time. It's only 7 days. And in the future, if the patient will not have the appropriate treatment, the changes will be progress and lead to the grave disturbances in electrolyte disbalance, and the function of other organs can
Uh,
be destroyed too.
can it happen because, doctor, it's not like the system, the hypothalamic pituitary axis was affected partially.
Maybe we cannot say is it partially or is it complete, but what methods should we provide more? We don't know what is the we seriously was this trauma for the pituitary region, and what should we do more? Patient has only 7 days after trauma, so we understand that not all pathological changes can be developed in this clinical case. Uh, not all.
Doctor, maybe we need to do further investigations like a CT scan, because according to research, head trauma always leads can sometimes leads to diabetes insipidus, and it's because sometimes the injury might affect the hypothalamus neurons in the pituitary gland. Could this be the case that we're looking at for this patient?
CT scan was done, was performed after the
And nothing, and they didn't see anything.
yes, and any changes was determined during CT scan examination. Uh,
Doctor, like the because the you said about the why the urine output was more affected, right? So it can be one of the reason that doctor the ADH kind of like regulates the water absorption in the kidney, and it can directly influence the concentration. So if there is a ADH disruption due to the fall, the kidney will not be like reabsorbing the water efficiently. So that will lead to large production of large volume of urine that can be like kind of like explaining why our patient has this kind of frequency of urination.
uh, we have in the clinic polyuria and polydipsia. Polyuria with huge amount of the water which is eliminated from the patient body. These symptoms can be typical for patient with what diseases, with what problem?
Diabetes doctor.
Hyperaldosteronisme?
First
Sorry,
of all,
go ahead.
diabetes mellitus. And we should differentiate this condition with diabetes mellitus too. Uh,
Yeah.
Stress factors could be risk factors for acute manifestation of the diabetes mellitus. And we deal with young patient, 21-year-old patient. And this patient could have diabetes more often, have diabetes type 1. This diabetes progress manifest with acute symptoms. Sometimes it's pre-comatose condition or coma condition. Um, it's typical for this variant of disease, but in the same time, could be not typical variants of disease progression and disease manifestation, and thirsty and polyuria could be two signs of diabetes mellitus. And we should control the carbohydrate metabolism for differential diagnosis for this patient. It's first line of our diagnostic process.
We can do the water deprivation test to check if it's the DI or ADH stimulation test, and for the to see like if it's diabetes mellitus, we can always do the first just the blood glucose test or HbA1 test.
Yes, of course, we should
Sorry, doctor.
provide
I
different.
can add maybe to this to what Samrin said. The injection of the Minera, the desmopressin, could be a good differential diagnosis if it's diabetic insipidus or not, because
Yes.
when we will, yeah, when we inject the desmopressin, we can see if we will enhance the natriuria or not.
I think, doctor, for the desmopressin, it will like more distinguish the central DI and if I'm not wrong, then we can put on like low salt diet and can check if it's like nephrogenic DI. I think it will also distinguish that if I'm not wrong.
Yes, we have a lot of abilities to provide different tests to determine or opposite understanding that it's impossible variant of disease. We could perform different provocative test for our patient, but in our mind we should remember that we have to differentiate, and patient could have typical and not typical manifestation and progression of some diseases, I mean diabetes mellitus too. And when the patient has thirsty and polyuria, we have to think about possible diabetes mellitus. Of course, we analyze all situation. We make analysis of disease appearing, disease early manifestation, uh, possible risk factors, possible reason, possible causes for disease appearing, and make conclusion about possibility of diabetes. Uh, mellitus or diabetes insipidus. So we always should differentiate. Kamran, yes, what do you want to say?
Uh, Doctor, I'm thinking regarding to anatomical situation of the pituitary gland. Perhaps this is the first posterior part of the pituitary
Yes.
gland, first part in trauma will damage, and this is the ADH is the first hormone lost. That means the diabetes insipidus is the first marker of the damage of the pituitary gland in the case of
Low
trauma.
lobe,
Yeah.
posterior lobe of the pituitary gland. Yes, but in the same time, we aren't sure that the trauma is affected only posterior lobe. And at the same time, we should control activity and function of anterior lobe too, because we don't know uh, how does trauma influence on the adenoma completely or only on the one part of it. Um, on the CT scan pictures, we didn't find any changes, but functionally, we find these changes a little bit later in our patient. So, other changes in hormonal activity of the anterior lobe could be developed later too. They aren't so quick in own symptoms and in own manifestation. So when the patient has information about brain injury, about brain trauma, we should control in this case all parameters of pituitary system. And we provide additionally all hormones test, TSH hormone, uh, hormones of thyroid gland, follicle stimulating hormone, luteinizing hormone, total testosterone, insulin-like growth factor, uh, basal cortisol level, and all of these hormones were in normal range. So we can make conclusion about affection of the low lobe of the pituitary gland. And this is the magnetic resonance imaging of the patient. And I try to make bigger. Later, some changes was found in the patient on this imaging. Near hypophyseal hyperintensity, bright spot cannot be seen. Uh, White arrow indicate anterior hypophysis, and red arrow indicates the absence of near hypophyseal hyperintensity, which should be present. So later, we doctors found the signs of low lobe affection in this patient, and blue arrows indicate dorsum sele and any changes in it. So sometimes we should repeat some tests for determining appropriate results when we have the clinic, when we have changes in subjective state, when we have some changes in objective parameters. We should repeat the some investigation, for example CT scan, or we instead CT scan we can provide magnetic resonance imaging, and after that made conclusion. For this patient was made desmopressin test and urine osmolarity. After 2 hours after inhalating of desmopressin was increased, and it indicates positive results of the test and indicates problem with antidiuretic hormones in the patient's body. Diseases which should be in list of differential diagnosis, it's diabetes mellitus, we have talked about it, and kidney disorders, because kidney disorders could progress with disturbances in quantity of urine, disturbances in urine specific gravity. Patients with kidney insufficiency typically have decreased specific gravity, but in our patient, where is he? What? Our patient has very low urine density, 1003, but in the same time, he has a little bit increased level of creatinine, and blood urine nitrogens is a little bit increased too. So it isn't correlated to each other. And patient does not have any information about previous problem with kidney. And the most important information that today during examination, patient does not have any changes in urine sample except urine osmolarity and urine density. Any other changes, any proteins, any red blood cells, white blood cells, cylinders, and other changes were detected. So we cannot talk about kidney disorders. Additionally, patient does not have any information about arterial hypertension, which are very typical for kidney disorders. Kidney diseases could progress with minimal subjective symptoms, but in the same time, we should find changes in the urine samples, and a lot of almost patients will have symptomatically arterial hypertension too. Our patient does not have such changes, so the diagnosis of kidney disturbances, kidney diseases is impossible in this variant of disease, clinical case. According to the result of desmopressin test, according to the low level of urine osmolarity, increased level of blood osmolarity, complaints on the polyuria, polydipsia, losing too much quantity, too much volume of the water, around 10 liters per day, we can suggest central diabetes insipidus in our patient, and trauma in anamnesis morbi. It could be reason, it could be cause for these changes and this variant of diabetes insipidus in our patient. Um, we can provide the different tests for determining activity and function of anterior lobe of pituitary gland. Everything was in normal range. To exclude adrenal insufficiency, adrenocorticotropic hormone stimulation test was performed with 250 micrograms tetracozactrin intramuscularly, and serum cortisol level were obtained on baseline and after 30, 60, 90 and minutes after injection, results was in the normal range. 10 milligrams of desmopressin acetate intranasal therapy one time a day, and reevaluated him after 5 days of drug therapy. After this therapy, patient demonstrate normalization of their complaints and changes in his organism. 4 weeks after the initiation of desmopressin therapy, the patient got better both in terms of clinical condition and laboratory results. Serum sodium level was decreased and get into the normal range. Urine density was increased to 1027, and urine osmolarity was 648. It is in normal range too. Patient recovered from the symptoms of polyuria and polydipsia with desmopressin therapy. But later, at the 6 months of the therapy, he started that his symptoms were recurring in the periods when he has forgotten to take his medication. Therefore, one conclusion was made. The desmopressin therapy was changed, and the conclusion about constant trauma affection of the posterior lobe of the pituitary gland was determined. So patient has permanent signs of brain injury, and patient needs to take desmopressin during maybe whole life, whole future life, for compensation disbalance in antidiuretic hormones in his body due to trauma, brain injury. And time to time, patients should be under the control over their blood osmolarity, urine osmolarity, electrolyte disorders, possible. So patients should uh, visit the doctors regular in his life for controlling over his condition. Do you have question with about this patient? Trauma is very frequent
No,
reason
it's
for.
okay. I think that it's yeah, it's something which is caused by the traumatism and the
It's the very frequent reason for this variant of disease and for affection of the posterior lobe of pituitary gland. So when you have patient with uh, unusual polyuria and polydipsia, first of all, of course, you should think about these hormone disturbances, and you should find in the patient anamnesis risk factor for this problem. And very often you can find trauma of the brain. Do you have more question?
No, doctor.
No, doctor.
Okay, and we can do the last patient case. A 49 years old female with complaints of the recurrent abdominal pain and irregular hypermenorrhea, muscle weakness, asthenia, hirsutism, visited a doctor. Also, she suffered from arterial hypertension and she was treated with a triple antihypertensive therapy, but she didn't have uh, enough effect of this complicated scheme of the treatment. In the same time, both parents had arterial hypertension, and her family history was positive for breast cancer. Objective examination revealed uh, obesity, body mass index 45.2 kilograms per quadrat meters. Stria distance was determined, hirsutism was confirmed, facial plethora, skin atrophy, and multiply hematomas was determined on the patient's body. Her glycated hemoglobin was slightly elevated and was 6.4%. What diagnostic suggestion do you have in this clinical case? Yes, Menike.
I think it's Cushing's
Uh,
because of
Cushing's
oh,
what?
I would say it's syndrome because I see um
Uh,
many
yes, you see
symptoms.
the laboratory test, but first of all, we can discuss symptoms which are typical for both conditions, for Cushing's syndrome and for Cushing disease. And for us, it's very difficult after physical examination and subjective examination to make conclusion what is the reason for these changes. These changes are very typical, but what is the cause of it? It's impossible to say. And tell me, please, one time more, what are the typical signs of Cushing disease or Cushing syndrome in this patient? Could you repeat?
I yes, I can see like a hirsutism is one of them, and stray is like a scene, and also I see like a multiple hematoma, which is like easy to bruise, and skin atrophy, and also like a centripetal obesity, which is kind of typical for the Cushing's syndromes or disease. And those are the things that we see. And
What also
yes.
does your patient have, which are typical for Cushing syndrome or disease?
Dr. 24-hour urinary free cortisol, which is
Um, yes, but I mean subjective and objective information, not laboratory data. Before laboratory examination,
okay.
what do we have in the clinic? What
Uh,
is typical for, what does it mean, Cushing syndrome or disease?
Doctor, the lack of energy.
Lack of energy, yes, weakness.
Yes, doctor, muscle weakness, and also
What is the reason for typical changes in case of Cushing syndrome and disease in peripheral blood? Why does patient has so typical changes in the appearance and some body characteristics are changed? Why? What is the main reason?
doctor,
Related.
I mean, are you talking about the physical examination, doctor?
Yes.
Doctor, like the patient is obese.
I mean, physical changes, but I want to ask you, what is the internal reason for these changes? Why does patient meet these changes in her appearance and her uh, health state?
Oh,
Is
it's
it
a
excessive
disturbance of a
cortisol?
it's a
Yes,
Excess
yes.
cortisol.
Yeah, because of the high cortisol.
Hypercorticism, yes, increased level of uh, definite hormones, corticosteroids hormones in her body. And corticosteroids hormones uh, have some effects on the different functions of the body. Uh, what
Uh,
are these effects?
so doctor, for example, high cortisol, it can like kind of like dilate the capillaries, which can like lead to like more flushed appearance to the face.
Mhm,
Um, and also cortisol, it has a catabolic effect, so it can break down a lot of protein, collagen, elastin in the skin.
mhm.
That can lead to the thinner skin, which is like more which is like more prone to bruise. And I mean, the patient also has excessive hair growth, which is kind of like cortisol can affect the androgen that can lead to the hair growth.
And what is the hormone influence on the carbohydrate metabolism and arterial blood pressure?
um so doctor, maybe because the Cushing syndrome, it also like affects on the body weight, and the adipocytes, they can like some sort of they can release like a lot of other hormones too, that can maybe lead to the higher like arterial blood pressure. And also, what was your question again? Muscle weakness and arterial blood pressure, doctor?
Not muscle weakness. I mean, what is the influence of corticosteroids on the blood pressure, on the cardiovascular system in general, and in blood pressure? And what is the influence of these type of hormones on carbohydrate metabolism?
Doctor, I mean, when this kind of like when the adiponectin and when there is like a lot of adipocytes which happen because of this obesity, there can be like a disruption of leptin and other hormones too, and that can affect the diabetes directly. And other than that, I think for someone, and also our patient is like 49-year-old woman, so it can be also something that how do I say, the cortisol can influence the body's fluid sodium balance, and that can like that can be like affecting the sodium, the high retention of the sodium and water, and increase the blood volume, and that can be like consequently driving the blood pressure. And also cortisol kind of like it acts like a vascular how do I say, vasoconstrictors. So that can be one of the reason why there is like higher peripheral vascular resistance, and that can also like put a lot of input in the blood pressure too. And also like the cortisol level and kidney function can be like related, and that can be like also if that's compromised, that can lead to the hypertension as well.
Okay, thank you. Kamran, what do you want to say?
Can say the cortisol impact on renin secretion, increase the renin secretion, and
Uh,
then angiorenin uh, that impact on the blood pressure, increase the blood pressure,
uh,
hypertension.
cortisols and corticosteroid hormones activate heart work, increased vessel tonus, and lead to the increase of the blood pressure level. And for using corticosteroids as a medication, or in case of internal reason for decreasing of steroids hormones, will be typical increasing of the blood pressure level. And it's very difficult to treat this variant of hypertension too. It's very difficult to control increased level of the blood pressure. And I mean, I want to say that corticosteroids are pro-insular hormones, and glucagon hormones, I'm sorry, and they stimulate increased level of glucose in the blood. So a lot of patients with disturbances of cortisol level have diabetes mellitus, or as a variant in intolerance to glucose as a previous stage of the diseases. With long progression of this hypercorticism, patient will develop very often diabetes mellitus, insulin-dependent diabetes mellitus. So our patient has typical changes in the appearance as a hirsutism, obesity, specific type of the obesity. Our patient has typical complaints on the muscle weakness, menstrual disturbances. She has also hypertension, and we have information that she has abnormalities in carbohydrate metabolism, because her glycated hemoglobin level is increased. We don't have yet information about change level of the sugar or specific complaints on the for specific complaints for the hyperglycemia, thirsty, polyuria, polydipsia, but at the same time, increased level of glycated hemoglobin demonstrate for us these abnormalities. And she has, during objective examination, uh, objective signs of skin changes too. So, stridiostensia, skin atrophy, hematomas also determined. So she has specific signs of cortisol hyperfunction, hypercorticism, and we should determine the reason of this hypercorticism. For this target, we prescribe different hormones for laboratory test, and we have results. ACTH is in normal range, but in the same time, basal serum cortisol level is increased. Serum cortisol level after 1 milligram dexamethasone suppression test is increased. Uh, Late night salivary cortisol is increased too. 24-hour urinary free cortisol is increased too. Other hormones and other parameters are in the normal range, I think. So any other changes from the hormonal activity, but after this laboratory test result, we can make conclusion about reason for these clinical changes. And tell me, please, now, what is the reason for disease in our patient? Is it Cushing disease or is it Cushing syndrome? And why do you think so? Yes, Beneki.
I think it is Cushing syndrome because,
Right.
first of all, we don't see the elevation of ACTH, which can be elevated probably with the pituitary gland
Mhm.
problem. But on the other hand, we see the elevation of cortisol and the reaction to the dexamethasone examination as well. So we can kind of see the elevations of all cortisol examination, which we can conclude that it is a problem from the adrenal glands itself instead of pituitary gland.
So
So, mhm.
we see two parameters which give for us information about ACTH not dependent hypercorticism, and we can make conclusion about localization of the pathological process in adrenal gland, definitely. These two parameters, it's definite level ACTH in the blood, it's in normal, and dexamethasone suppression test results. During ACTH suppression, patients demonstrate increased level of cortisol in the blood, in the saliva, in the urine too. So it's signs of localization of the pathological process, definitely in adrenal gland. And uh, what reason could be for these disturbances? What is the process could be detected in the adrenal gland? And what method of diagnostic should we provide to determine this possible problem, these possible diseases?
It could be a tumor of adrenal glands, and we can probably see it by doing a CT or MRI and see if there is any like a tumor around the adrenal glands.
Mhm. And magnetic resonance imaging test was performed, and in this test we determine the tumor of the left adrenal gland, solitary tumor, and surgery treatment was recommended for this patient. Uh, Histological examination of the adrenal adenoma with gematoxylin and eosine uh, demonstrates solitary, well circumscribed intraadrenal mass in the gland. Uh, So, diagnosis of cortisol producing left side adrenocortical adenoma was determined. For patient was recommend laparoscopic left side adrenal ectomy. In post-operative period, morning serum cortisol level was less than 50 micrograms per deciliter, and for replacement therapy was prescribed glucocorticoids. This operated was made in 2015 year. I think, just I check. No. I'm sorry. Between February and May 2015, antihypertensive therapy could already be reduced to only one drugs. So, type of the arterial hypertension was changed, and this hypertension was in the control only with one drug, one medicine. So we remove decreased level of cortisol, we remove negative influence of increased level of cortisols on the cardiovascular system, and we have effect. We have controlled blood pressure level with minimal medicates. Hydrocortisone was stopped in May of this year, taking into account a normalized adrenal function measured by an ACTH stimulation test, and no clinical evidence for an ongoing glucocorticoid withdrawal syndrome. In August 2015, the patient reported a weight loss of 5 kilograms and an improvement of her general condition. So, step by step, the patient condition was better, and symptoms and pathological changes, which was described earlier, was removed and decreased. The 1 milligram dexamethasone suppression test and the late night salivary cortisol results were remarkably lower than previously, but not normalized. In contrast, 24-hour urinary free cortisol test was within the reference range, and the ACTH was no longer suppressed. This patient was under the control during a lot of years. 2 years after adrenectomy, the antihypertensive therapy was discontinued, and the patient did not take any medication at all. Additionally, level of glycated hemoglobin was clearly improved, and the lowest level was 5.5 in April 2017. So, carbohydrate metabolism turn on the normal, and patient does not have definite problem, significant problem with carbohydrate metabolism too. So all symptoms was decreased in our patient. But in April 2018, patient reported complaints of the proximal myopathy, moderate fatigue, and weight gain of 5 kilograms in 6 months. Her general practitioner had already restarted antihypertensive medication because of uncontrolled blood pressure. So, some of the symptoms come back, and after April 2018, 3 years after surgery, she again have the signs of cardiovascular problem, weight gain, uh, and additionally proximal myopathy and fatigue. So, what conclusion can be made after appearing of these symptoms?
I mean, we can again suspect something happened to her body, and she is again having a Cushing syndrome for some reason.
She again has hypercorticism, yes, and she
Hypocorticism.
demonstrates typical symptoms of progressing and worsening condition and appearing increasing level of corticosteroids hormone cortisol in her blood. And of course, what should we do in this case?
We can check her blood, blood like a laboratory, like results, just to see again the ACTH level and cortisol level. And also we can confirm with the CT and MRI
Mhm.
if there is any tumor or problem in the adrenal gland or maybe in the pituitary gland. We don't know yet.
It could repeat in situation with tumor. Of course, when the some cells can be stay in the patient organism and lead to the appearing new attack of the tumor in our patient with increased production of uh, corticosteroids. And of course, we should prescribe all laboratory and instrumental data uh, which can help us the condition, the level of hormones, the reason, the cause of hormones changes, and we should prescribe additional examination to determine the carbohydrate metabolism. We should control cardiovascular system because around 5 years after first operation, and we don't sure that everything is okay, and maybe some other diseases appears, new diseases appears in the patient's body. In these diagrams, you see a dynamic of some parameters in her body during these 5 years. ACTH, uh, dexamethasone suppressive test, night salivary cortisol test, and quantity of cortisol in urine. And you see uh, the on almost diagrams, we see periods before April 2017 with stable condition, with normal activity of hormones, ACTH hormones, and cortisol in the blood, in the urine, uh, and normal reaction on suppressive dexamethasone test, but before April 2017. After that period, gradually we observe increasing of the ACTH level, not very quick, but step by step, changing in dexamethasone. I'm sorry, I tried to. Dexamethasone suppressive test and absence of, oh, it's better, uh, absence of adequate suppression after injection of dexamethasone or taking some dose of dexamethasone. Late night salivary cortisol level uh, to increased, and elimination of cortisol will with urine uh, was increased too. So we have repeating of the process, and again the patient has hypercorticism, unfortunately, but some other changes are determined in her body and her blood. And during examination in April 2019, Level of ACTH was increased. Basal serum cortisol in the normal range, but after dexamethasone suppressive test, we have increased level of cortisol in serum, in urine, and in level cortisol in urine too is increased. When the doctor prescribe examination of the adrenal gland and pituitary gland, uh, different changes was determined. One moment. During magnetic resonance imaging, uh, was determined the problem in pituitary region, the adenohypophysis, and you see these changes in the pictures with white arrows indicate a hyper-intense focal lesion, not very big, but it could be determined with MRI. In the dorsal part of the adenohypophysis, and during this examination was determined microadenoma. So patient was recommended surgery treatment, and after surgery treatment, basal ACTH was less than 5 nanogram per liter, and cortisol levels were suppressed. And in this clinical case, you see two studies or two variants of disease. First time, patient has Cushing syndrome due to adrenal adenoma, and after 5 years, patient develop Cushing disease with microadenoma of adenohypophysis and appearing of the ACTH related dependent hypercorticism and Cushing disease. So it isn't a very frequent situation when the patient has recidive of Cushing changes typical for Cushing syndrome or Cushing disease, but with different cause of these changes. First episode was as a result of primary hypercorticism due to adrenal adenoma, and the second episode was a result of pituitary gland affection and appearing progression of microadenoma of the pituitary gland with increased production of ACTH and increasing of cortisol level and appearing the typical changes, typical symptoms for Cushing disease in this patient. So in one case, we discuss situation with Cushing syndrome and Cushing disease, differences in hormonal level, and ways of treatment and diagnostic process. Do you have question about today patient?
No,
No, it's okay,
No,
doctor. It's
doctor.
very interesting. Thank you, doctor.
Thank you for your attention and for your activity. Thank you very much. Tomorrow, every student should prepare case history. You should have practical skills and you should write case history. In this variant, you shouldn't do presentation, only Word document with brief information about complaints, anamnestic data, objective data, uh, suggested diagnosis, plan of the examination, uh, list of differential diagnoses, uh, and after that, plan of the treatment of the patient. So these parts should be done for a clinical case. You can choose pathology, what do you want? It could be endocrinological pathology, of course. It could be thyroid gland disorders, adrenal gland disorders, pituitary system or hypothalamus disorders. So it's up to you. You choose everything. You make a short case report about your clinical case. And tomorrow we have around 3 hours, and we have around 15 students in our class. So I think not more than 10 minutes should take your presentation. Okay, not more than 10 minutes, because sometimes some discussion or some questions should be done. So maximal 10 minutes presentation of clinical case with all information about patient, subjective, objective, additional laboratory data, and conclusion about diagnosis, differential diagnosis, plan of examination, plan of the treatment. Is it clear?
Yes, doctor.
Okay, so
Okay.
tomorrow we meet at 2 p.m. as
Sure,
usual.
doctor. Yeah.
Okay, thank you, doctor.
We'll
Sorry, doctor. Yesterday I was connected, but I was in travel, so I didn't participate. I don't know if you have put me present or if